We will be starting our webinar now. Hello and welcome. And I want to thank all of you for joining us here today and taking the time out to give us the time today here in this afternoon. Today, we are welcome to the webinar on inclusive safeguarding programming for persons with disabilities from the Safeguarding Resource and Support Hub. I'm Firdaus Nahid, National Representative, RSH Bangladesh. Our today's webinar, Inclusive Safeguarding Programming for Persons with Disabilities, is to understand disability and the increased care risk and challenges faced by persons with disabilities from Bangladesh when they are interacting with NGOs, and to explore potential risk mitigation measures for CSOs who are implementing programs in humanitarian and development sectors. The RSH is a program that aims to support organizations in the development and humanitarian sector to strengthen their safeguarding policy and practice against sexual exploitation, a- abuse, and sexual harassment. RSA supports all organizations working this sector, but is driven by the needs of smaller nations and or local organization. RSH is funded by UK Aid, the UK government's Foreign, Commonwealth, and Development Office to help organizations around the world. And is a consortium led by Options with Social Development Direct as the technical and delivery lead, and including the International Council of Voluntary Agencies, Third Day Homes Site Savers, and Clear Globals. Now I will share the agenda of today's event, and we really want to talk about some overarching principles that should be considered when applying a safeguarding approach for persons with disabilities. RSH has developed a tip sheet that describes some specific recommendation for applying a disability inclusive lens to safeguarding. We'll share the link to this at the end of the webinar. After me, we have the first panelist, Taslima Akhtar, coordinator and safeguarding focal for Center of Disability and Development. Will discuss on what we mean by disability and the different type of disability there are. The Lima will also discuss why our people with disability are at increased risk, and she will also share the findings. Our second speaker is Mostarin Samantharamanan from Age and Disability Technical Working Group, Intersector Coordination Group, Rohingya Refugee Response. Cox's Bazar, Mostarin will share learning on some of the challenges faced by implementing programs and what can organizations do to have disability inclusive safe programs. The last section of the webinar will be a Q&A where you can ask questions to the panelists. Finally, several questions will appear at the end of the webinar for you to provide us the feedback on the event. Without further ado, let me share my screen and start with the overarching principles and recommendations. Now, what are those overarching principles that we want to talk about? And I want to mention 3 principles here today. So I really want to focus on inclusion and non-discrimination. People with disabilities are often unconsciously excluded from safeguarding activities, meaning that the specific risk factors they experience are not captured in initial planning processes. Now, what we can recommend or what actions can be considered by CSOs? Ensure you are applying a disability lens to all planning processes, ensuring inclusive safeguarding is built in from the start. Work with people with disabilities across all ages, genders, and social economic status, and their representative organizations as key stakeholders in the programming. Consider diverse workforce to increase the focus on intersectionality. Develop checklists that reflect intersectional approaches. For example, ensure that the checklist reflects the differential needs of both women with visual impairments and those with hearing impairments. When organizing any workshop for or training, ensure the location, materials, and facilitation methodology are gender and disability sensitive, inclusive, and accessible. Those are the actions can be considered by CSOs. So these are the actions that are actually very important and very inclusive that can be considered by CSOs, and we recommend these things to be considered by CSOs once they are actually in a planning stage. Now, if we are talking about the second principle, that is accessibility. People with disabilities may have difficulty in accessing services in the same way as people with disabilities without disabilities. This may place them in situation with greater risk. Consider sanitation facilities, for example. Services to support CA survivors may also inadvertently exclude people with disabilities if those services are provided in structures that are inaccessible or if the staff lack awareness of disability. A person who is blind or finds communication or reading difficult may also experience challenges in making a complaint, especially if there is a reporting mechanism that requires a person to write. Similarly, alternate reporting mechanism, for example, for deaf people or people with intellectual disabilities may compromise one's confidentiality and safety, thus increase risk further. So what actions can be considered? Consider the increased risk posed by inaccessibility in project design and implementation. Ensure that there is a more than one reporting mechanism and that they are designed collaboratively with people with a variety of impairment who will be engaged in the program. Consider involving people with disabilities and their representative organization in the design of SIA messaging and communication to ensure that a range of accessibility features are included. Involve people with disabilities from the outset of in information and awareness raising activities. Third principle, we're going to talk about gender equality. Women, girls, and adolescents with disabilities are in greater risk. Individuals who look for opportunities to exploit women, girls, and adolescents may target those with disabilities because they may assume that they are at easy target who will also not be able to make a complaint or be taken seriously if they do make a complaint for various reasons cited above. People with disability and their representative organization may also not have a strong awareness of the issue experienced by their female members or women may not be in leadership position. So what actions can be considered? When engaging with people with disabilities and their representative organizations, seek out diverse representation that includes women, girls, adolescents with disabilities from different settings, as well as people from different impairment groups. Integrate a disability lens into all gender mainstreaming and gender targeted interventions that aim to empower women, girls, and adolescents with disabilities. Now, I would like to talk about RSH recommendation for applying disability inclusive lens of safeguarding. That we have tips listed in the table below that are, not exhaustive but are relevant across the context. We have a list: accessibility, capacity, and target. We are talking about accessibility. Once we talk about accessibility, but we will be sharing this link with you in the chat box to know the detail on this. On this detail to know about it, we want to move on to our first panelist, Taslim Akhtar, and she will be presenting us Coordinator Safeguarding Focal Center for Disability in Development. Thank you, Nahid Bhai. I'm delighted to have the opportunity to present today. It is a pleasure to share the inclusive safeguarding approaches implemented by CDD. Before delving into my presentation, allow me to introduce myself, provide an overview of organization. I'm Taslima Akhtar, serving as Senior Data Coordinator at CDD, an organization established in 1996 with vision to create inclusive world where everyone lives with dignity. Today, our concept is to talk about inclusive safeguarding. But before we proceed, let's grasp the concept of what is inclusion, which is intricately linked with the idea of inclusivity. Inclusion is a process aimed at addressing the diverse needs of the people at increased risk of harm due to mobility or communication challenges, with the goal of ensuring they can play an equal role in the society. For instance, in our work at the Rohingya camp, we encounter a diverse range of individuals, including women, men, and the elderly children, and persons with disabilities. When devising safeguarding strategies for them, it's imperative to consult with them first to identify their specific needs, taking into account intersectionality. This process is inclusion. When environment is ready to accept all diversity and everyone feels safe, respected, and dignified, participating equally with others, it is called inclusive. Inclusive is a result. Inclusive promoting diversity, equity, empowerment, and a sense of belongings. Inclusive means they have to feel safe, they have to feel respected, and they have to feel dignified. And they have to feel that they can participate equally. So we can actually focus and tell that inclusive actually promote equity and empowerment and the belonging. Inclusive safeguarding acknowledges the diverse backgrounds, identities, abilities, and risk of people. Therefore, policies, procedures, and interventions should be designed to be inclusive of these differences. Inclusive safeguarding prioritizes the safety and well-being of all individuals, regardless of their backgrounds, actively addressing any barriers to their participation and protection. Here are some key principles of inclusive safeguarding. So once we talk about some principles, I really want to focus on few principles in brief. Well, definitely it's not in the details. So I want to mention the principles like accessibility, ensuring that protective measures and information are accessible to individuals with diverse abilities, language, or communication methods, diversity and cultural sensitivity, recognizing and addressing the unique needs, vulnerabilities, norms, value different and communities. Third, equity, ensuring fairness, equity in protecting all individuals from harm. Intersectionality, recognizing, addressing the intersecting factors that contribute to individual vulnerabilities. Next comes participations, actively involving diverse stakeholders in the design, implementation, and evaluation of safeguarding measures. We talk about empowerment, acknowledging the voice of diverse group and considering their opinions, experiences, and feedback. And next come enhanced community trust, building trust within communities by demonstrating fairness and inclusivity in safeguarding measures. And last, long-term impact, fostering a culture of inclusivity and safety for the overall well-being and development of diverse group. Today's webinar focuses on inclusive safeguarding for persons with disabilities. To begin, let's understand what constitutes a disability. According to the UC and CRPD and the Rights of Protection Act 2013, person with disabilities encompasses those with long-term physical, mental, intellectual, or sensory impairment, which when combined with various barriers may impede their full participation in society. It's crucial to distinguish between impairments and barriers, as addressing barriers effectively can significantly enhance participation and integration. The barrier can be varies. The barriers are different. Barrier can be defined in many ways. It's an environmental barrier, communication barrier, societal barrier. Barrier can be outside, from the outside. It's not an internal barrier. It comes from outside. So once it comes and pairs with the internal barrier, then it calls the disability. So that's how the person comes or makes it so wholesome as a disability. And the CSO can address those barriers and CSO can work on that part on the barrier side, how to identify and work with the barriers. UNCRPD outlines 4 categories of disabilities: physical, intellectual, mental, and sensory. Additionally, the Rights and Protect Act of Person with Disabilities Act 2013 identifies 12 types of disabilities, including autism, physical disabilities, mental illness leading to disabilities, visual disabilities, speech disabilities, intellectual disabilities, deafness or hearing loss disorder, hearing visual, cerebral palsy, Down syndrome, multiple disabilities, and others disabilities. Why this other disability? Because if something other comes, what is not defined, so there is a governing body and they are want to recognize other disabilities, it will be included and we have a scope to include that. Persons with disabilities encounter unique challenges that increase their risk of exploitation and abuse. These challenges include stigma and discrimination, dependency on caregivers, social isolation, communication barrier, and the lack of understanding about abuse and how to report concern. Stigma and discrimination often marginalize persons with disabilities, hindering their social integration and participation. Dependency on caregivers can create power imbalance, increasing the risk of exploitation. Social isolation further exacerbates vulnerability, while communication barriers and limited understanding of abuse hinder their ability to seek help and protection. That's why they are in more greater risk than other peoples. In programs, people with disabilities face discrimination, exclusion, and heightened risk of harm, including sexual exploitation. While I was saying in the beginning, once we design in a program, safeguarding approaches often lack disability inclusion and intersectionality, leaving people with disabilities vulnerable and unprotectable. We have a limited understanding while we are in the stage of designing programs, and that's how it results to a discrimination. And this is put the disabled people to a severe risk. So this is very important, as I was mentioning in the beginning, that this is very important that working in the planning stage and we are working in a mainstreaming organization, it is very important how we are designing the inclusion planning and how we are actually understanding the lens of inclusion. And we have a lack of capacity or lack of understanding. And as a result, we are not designing the protection wisely, or we are not working on the planning stage wisely. So we have lack of capacity or in the lack of capacity at the staff level. Now I want to focus how we are actually doing the practice in CDD. We are doing analyze the community profile and local context to set up in this mechanism. To set up ICFRM, first we evaluate demographic, social economic status, cultural norms, and specific needs. Understand local dynamics, including existing feedback mechanism and communication channels. So as a CDD, we do analyze first to understand the community profile and local context. Second, we work on consultation with communities to determine channels, engaging with community members to identify proactive, for example, surveys, focus group discussion, door-to-door visits, and reactive feedback, for example, feedback boxes, hotline emails, channel for gathering, and we use different channel for gathering those feedbacks. So we always keep it moving on to collect those feedbacks. Third, establish ICFRM infrastructure of information informed communities. We set up necessary infrastructure and tools for feedback collection, management, and response, inform communities about the system implementation. We also work on orientation and community awareness. We conduct orientation session to educate community members about ICFRM, clarify the feedback collection process, and emphasize their participation's significance so that the awareness programs keeps live and going on. Then we work on develop action plan and staff training. We create protocols for receiving, analyzing, and responding to feedback. We train our staff on active listening, empathy, and effective communication. And we do focus on continuous monitoring, learning, and improvement so that every case is reported continuously. Monitoring ICFRM effectiveness, including feedback collection rates, response times, utilize feedback insights to enhance system responsiveness and inclusivity through continuous improvement. To ensure inclusive safeguarding for disabilities, we have followed these key principles. Inclusive program design, develop programs that consider diverse needs, abilities from the outset. We do capacity development, equip stakeholders with skills and knowledge to support disability inclusion effectively. Accessible communication, we ensure information is available in various formats to accommodate different disabilities. We do awareness, raise awareness about disability issues and the importance of inclusion. We work on inclusion policy development. We create policies that address the rights and needs of people with disabilities. We collect data that is broken down by disability to understand specific challenges and needs in the disaggregated data section. And next point, it's empowerment. Enable people with disabilities to assert their right, participate fully in society. Meaningful participation. Ensure people with disabilities are actively involved in decision-making process. In last, collaboration. Work together with stakeholders across sectors to promote inclusive practice and policies. And the whole process helps us to address the complete needs of the disabled person so that multiple collaboration if required, we can design that, and the complete process helps us, and the key principles helps us to design and implement the complete programs. And it helps us to address the process and implementation. When When we think and implement the program, we follow these principles in CDD. Thank you for listening all the points, and these are the all points that we do practice in CDD. And what I recommend that this was the learning we received from CDD, and I believe this also you can follow if you really want to implement as a CSO. Thank you, Taslima Appa. As you shared, there is the detailed findings from your organizations and how you address the risk and challenges, and you recommended few steps. Those were very helpful, and I'm sure this is gonna help us with this recommendation. And I want to move to Mustarin Appa, and who's working with intersection coordination group, and to share her learning from her organization. And I'm welcoming her for sharing her session. Thank you so much for this, Bhai. Thank you all the colleagues, and it's a very good afternoon. My name is Mustarin Samada Rahman. I'm with Age and Disability Coordination at the Intersector Coordination Group. For the Rohingya refugee response, I will be discussing disability inclusion programming, barrier with inclusive programming, as well as some lesson learned from Rohingya response to refugee response program in Cox's Bazar. I will be talking with some barrier with the disability program, and I will also be sharing with some lesson learned from our Cox's Bazar project. Especially, I will not add anything from the add on the what is disability, because my previous speaker added a lot learning from Taslima Appa. But I want to highlight one thing, that once we work with disability inclusion, once we work with disability inclusion is achieved when person with disability meaningfully participate in all their diversity, when their rights are promoted, and when disability related concerns are addressed is in compliance with the Convention of the Rights of Person with Disability. Disability inclusion usually requires a twin-deck approach. The first step is mainstreaming humanitarian programs and intervention, and the second step is addressing specific requirements through targeted intervention. It basically indicates the alongside intervention designed for the rest of the person of concern. Must-do actions are required if persons with disabilities are to be included successfully in all phases of humanitarian action, and needs to be taken by every stakeholders in every sector and all contexts. The four must-do actions described below should be kept in mind when reading or applying each sector, chapter, and the section on stakeholder roles and responsibilities. We talk about promote meaningful participation, remove barrier, empower persons with disabilities and support them to develop their capacities, and disaggregated data for monitoring in inclusion. So the convention, if we talk about barrier, neither inclusion nor participation can be achieved while barrier remains. Removing attitudinal, environmental, institutional barrier is critical addressing risk. But if we talk about disaggregator to monitor inclusion, data on barriers and on the requirement of person with disabilities are essential. Humanitarian data should include disaggregated data on disability to ensure that humanitarian action planning, implementation monitoring are accessible to end and include person with disabilities. Data and information on risk and barriers faced by person with disabilities should also be collected and analyzed. This will strengthen humanitarian stakeholders' understanding of the barriers to inclusion, which in turn will enable them to remove them effectively and adopt measures to promote inclusion. But if we talk about empower persons with disabilities, humanitarian stakeholders, including organization of persons with disabilities, needs to develop their own awareness of the right and capacities of persons with disabilities. Then they need to work with persons with disabilities to strengthen and extend their capacities. This Steps, steps together empower both group of stakeholders to ensure that persons with disabilities are fully included in the all aspects of humanitarian assistance and protection. Let us now take a look at barrier. A number of barrier pose challenges in implementation, including inclusive and safe programming for persons with disabilities. I'm going to discuss some of the barriers, however, there can be many more. Physical barriers are structural obstacles in natural or man-made environments that are prevent or block mobility or access. Example of physical barrier include steps or curbs that block a person with mobility impairment from entering a building or use a sidewalk. The Cox's camps have huge landscapes that are often quite difficult to navigate, imposing physical barrier to programming. So Cox's landscape is a very big example for the lack of or disabled person, that how difficult it is or how challenging it is for mobility. Environmental barrier. This refers to barrier posed by the environmental condition of the geographic location that the person resides in. For example, heavy rain in Cox's Bazar is an environmental barrier to refugees with disabilities, as well as inclusive programming resulting in higher levels of issues with mobility because of the water blocks, flood issues, or the water level is high. It's who are the who cannot move, or the mobility is not is a challenging things for the disabled person. They face a greater challenge, and it is very risky for them. So the geographical challenges or the environmental barrier is very high in this landscape. Institutional barrier, policy barriers are frequently related to a lack of awareness or enforcement of existing laws or and regulation that requires programs and activities be accessible to people with disabilities. Examples of policy barrier includes denying qualified individuals with disabilities the opportunity of to participate in or benefit from federally funded programs, service, or other benefits, denying individuals with disabilities access to programs, services, benefits, or opportunities to participate as a result of physical barriers. Policy-wise, Bangladesh has passed a number of laws establishing the right of persons with disabilities, but yet a lot of scopes are there left still to develop a different sort of adjustment in that policy. So in that, we know that already in the job placement or employment placement, there are a lot of scope that we can include disabled person, how to include them. So we have scope to develop those policy and laws. Now I want to talk about a little bit of a social barrier. Social barrier are related to the conditions in which people are born, grow, live, learn, work, and age, or social determinants of health that can contribute to decreased functioning among people with disabilities. It is needless to say that refugee camps pose a myriad of such barriers and challenges. Then there is a communicational barrier. Communication barrier are experienced by people who have disabilities that affect hearing, speaking, reading, writing, and understanding, who use different ways to communicate than people who do not have these disabilities. Examples of communication barriers include written health promotion messages with barriers that prevent people with vision impairments from receiving the message. These include use of small print or no large print version of material, or no braille or version of people who use screen readers. We face this issue during dissemination of messages. They are done over microphones in the camps, and often the messages are regarding emergencies and evacuation. During emergencies, going door to door is also difficult within a short period. So for this message, we mostly rely on family members and caregivers to ensure the safety of the person with disability. There is an internalized barrier. Internalized barriers present themselves when a person with disability limits their own perception of their rights. For example, a child with disability in the Rohingya camps may start thinking that education is not something they can achieve. This barrier result is low participation or engagement. There is also a phenomenon that is present in the camps, and initiatives are taken to empower them through targeted awareness and community engagement programs. Then there is a programmatic barrier. Programmatic barrier limits the effective delivery of a public health or healthcare program for people with different type of impairment. As I was saying, we don't have a policy level barrier in our country. We have an implementation barrier in the programmatic level. Example of programmatic barrier includes inconvenient scheduling, lack of accessible equipment, insufficient time set aside the medical examination and procedure, little or no communication with patients or participation, etc. In the Rohingya camps, we also see projects often being implemented with no planning to specifically include persons with disabilities. So I only focus on this kind of barriers, and stigma is very high. I really want to mention on that. So we do have the resource, but we can't do them effectively. We do not have enough volunteers, or we do not have enough caregivers. Lack of caregivers, lack of a volunteer. We do not have enough human resource. We do not have enough grants to do that or enough funds to do that. So those are the lackings we do have in the programmatic level. So we do not have much time to explain all these things, but we do have good practices here. Uh, but we do have good practices that we have put focus on these practices, that we are practicing on the good part, addressing those barrier and implementing that how to reduce those barrier and risk mitigation. And in this case that we are when we look at some good practice, the age ICG, which is quite rare compared to some of the other responses. There is a strong presence of disability focused organization in response. There is also active engagement of organization of persons with disabilities and self-help groups within the um, response. Awareness raising and AMH PSS of caregiver are also conducted as part of the inclusive response. Also, additional assistance and rations are provided to households that have family members with disabilities. So in my last slide for the day, uh, I want to say that on the day forward, some of the strategic priorities of the working group are to establish and mainstream age and disability response across all sectors and partners. We have some recommendation. These are the recommendation that we talk about to improve the existing data on disability, rigorous evidence-based advocacy to reach donors and other stakeholders, to improve involvement of persons with disabilities in program cycle, to increase more accessible facilities in camps, to establish and strengthen responsive and reliable complaints and feedback mechanism for persons with disabilities, and to strengthen coordination at camp level through improved engagement between disability focal point and other sectoral focal point and team. But that's all from my side today. And I'm very happy to share the learning from my side, but I think our recommendation will help all the CSOs and learning will help all the CSOs from my side. Thank you, Mustarinapa, for highlighting the important part and especially highlighting the learning from the geographical aspect. that what are the challenges you faced and how you address those one. Now we would like to move to the question and answer section. And I have my colleague Lumna with me to help in the question and answer section. I will try to answer shortly. We follow the Washington group of questionnaire. We follow that principle. We have a set of questionnaire which is long and short. Washington group of questionnaire. There is a sixth set of question. That's a global standard of question, and that is very helpful to follow once we try to identify those answers. The next question is, the barrier is physical or psychological or psychosocial? Is different kind of barrier. There is a barrier called attitudinal barrier, which is an internal barrier. It is a barrier remains in the disabled person, that what they feel from inside, that they are not good enough or perfect to do that thing they cannot achieve. That is another barrier is an environmental barrier or communication barrier, that is the outside barrier. So there are a lot of barriers, environmental barrier, communication barriers. So there are a lot of barriers imposed by outside barriers or social, and there are few barriers that is actually developed inside. If we go back to the definition of inclusivity, this means inclusive for all. Once we really talk about inclusive, it means diversified people, most vulnerable people. So we are actually talking about including diversified people. So have to consider the intersectionality. So once we talk about disabled, so when we're talking about disabled, then we are talking about what is the gender of that disabled people, woman. So it is about considering everyone, considering every gender, considering every disability. For the next question, how to involve the disabled people in the process. So there are a lot of active NGOs are working in the uh, field right now. So it's very important to how to include in the program sector. So as we said that CDD, how it does, they do a twin tracking program. They add they make the mainstreaming program how they work for other people, and they design a focused program for the disabled person. So that's a very easy way you can make it an inclusive program. Or you can make an inclusive design where you can make a portion of your program, or you can make a plan in your program part to include those disabled people in a program planning. We are receiving a lot of questions, but maybe we will not be answering all the questions right at this moment in the live, but definitely we will be writing them in the chat. And we have a lot of resources in our Resource Hub website. We will be requesting everyone to go and please check the resources. It is very helpful for everyone, and it is you can all have it there. And I want to close here the Q&A session here. I want to thank all of you for joining today's webinar, and I want to request everyone to visit RSH website. Please visit our website, explore the resources available there, and take as much as possible resources and knowledges so that it can help your organization, your CSOs. It was all our discussions today. Please stay well. Thank you. Thank you for joining.